Under the microscope, this dense infiltrate of pink and purple cellular structures presents a dangerous trap for hematopathologists. It is a plasma cell-rich reactive lymph node. The World Health Organization's 5th edition classification groups two distinct entities, IgG4-related disease and Castleman disease, under the same broad umbrella, tumor-like lesions with B lymphocytic predominance. These lesions share an alarming set of overlapping features. Both can present with generalized lymphadenopathy, florid follicles, striking vascular proliferation, and dense sheets of plasma cells, accompanied by severe systemic symptoms. Relying solely on morphology to tell them apart, or to separate them from an aggressive lymphoma, leads directly to misdiagnosis. The tissue architecture alone is an illusion. The only safe path forward is a strict, multimodal workflow. We must start at the plasma cell-rich node and branch outward, integrating the anatomical distribution of the disease, targeted viral testing, and an analysis of the patient's inflammatory serology. Navigating this diagnostic algorithm is the required standard of care. Tissue gives us the opening question. The clinical context provides the answer. Following the first branch of the algorithm, we assess the lymph node for the presence of IgG4-positive plasma cells. This introduces our primary diagnostic hurdle. Finding more than 100 IgG4-positive cells per high-power field, alongside an IgG4 to IgG ratio above 40%, does not equal a diagnosis of IgG4-RD. Highly elevated IgG4 counts are frequently triggered by aggressive mimics. Multicentric Castleman disease and marginal zone lymphoma routinely flood lymph nodes with these exact same cells. Furthermore, IgG4-related lymphadenopathy lacks a single visual standard. It manifests in 5 distinct nodal architectures, from Castleman-like to inflammatory pseudotumor-like. Noticeably absent is the classic extranodal triad. The storiform fibrosis and obliterative phlebitis expected in pancreas or salivary biopsies are usually absent in nodes. To safely rule out a hidden neoplasm, we face a strict requirement. We must use light chain testing to prove these plasma cells are polytypic. A monotypic population heavily favors lymphoma. True IgG4-RD is a clinical diagnosis. It requires compatible extranodal organ involvement, relatively mild nodal enlargement, and normal or only modestly elevated C-reactive protein. We move to the next branch of our algorithm, cases where Castleman-like histology is restricted entirely to a single anatomical lymph node station. This defines unicentric Castleman disease, or UCD, a strictly localized HHV-8 negative disorder. UCD predominantly displays a hypervascular morphology. B lymphocytes form tightly packed concentric rings around regressed germinal centers, creating the characteristic onion skin mantle zones. You will also frequently find hyalinized vessels physically penetrating these regressed germinal centers, resulting in a distinct lollipop follicle appearance. Beneath this architecture lies a massive expansion of the follicular dendritic cell networks. This specific structural distortion carries a well-documented risk of secondary FDC sarcoma. Because UCD remains localized and lacks the severe systemic inflammatory storms seen in other subtypes, complete surgical excision is often curative. The mechanical removal of the node eliminates the disease. The algorithm splits sharply when multicentric disease is driven by a viral infection. We enter the domain of HHV-8-associated multicentric Castleman disease. The clinical profile here is severe and systemic, striking immunocompromised patients, particularly those with HIV, presenting with high fevers, surging C-reactive protein, and Kaposi sarcoma. The pathogenesis is a viral hijacking. HHV-8 infects plasmablasts and forces them to encode viral interleukin-6, weaponizing cytokine pathways to trigger systemic inflammation. Proving this diagnosis requires one absolute microscopic finding. Immunohistochemistry must demonstrate distinct granular punctate brown nuclear staining for the HHV-8 LANO1 antigen. But these infected plasmablasts set a dangerous immunophenotypic trap for the pathologist. This flow cytometry plot illustrates the danger. The HHV8-positive plasmablasts often show overwhelming lambda light chain restriction phenotypically. Yet analyzing their immunoglobulin genes reveals this restriction is an illusion. The cells remain genetically polyclonal. They are not a single destructive clone. Misinterpreting this phenotypic lambda restriction as a true malignancy will lead to a disastrous misdiagnosis of plasmablastic lymphoma. Identifying LANA1 proves the patient is suffering from a viral-driven cytokine storm. It dictates an entirely different therapeutic pathway, centering on rituximab-based therapies and aggressive HIV management. The final branch of the algorithm addresses patients with systemic inflammation and multicentric nodes, but who test completely negative for HHV8. IMCD is a strict diagnosis of exclusion. We must actively rule out major mimics, Poem syndrome, autoimmune disorders, lymphomas, and viral infections. This chart of laboratory criteria shows what proves active disease: high C-reactive protein, marked anemia, and broad polyclonal hypergammaglobulinemia. The biological driver behind this chaotic clinical picture is a hyper-IL-6 state, flooding the system and causing multi-organ dysfunction. Within this idiopathic category exists a distinct, exceptionally acute, and often severe clinical variant known as IMCD-TAFRO. TAFRO represents an aggressive phenotype defined by its exact acronym: T for thrombocytopenia, A for anasarca, F for fever, R for renal dysfunction, and O for organomegaly. We separate TAFRO from standard IMCD by looking at the margins. TAFRO patients typically present with small volume lymph nodes and lack the striking, massive hypergammaglobulinemia seen in the standard plasmacytic variant. The systemic cytokine storm drives the clinical course of IMCD. Because this inflammatory state exists beyond the lymph node, it requires targeted anti-IL-6 therapy. Zooming out, we see the complete diagnostic workflow. What begins as a single morphological pattern fractures into distinct localized, viral, and idiopathic pathways. But the ultimate fear driving this entire framework is missing a lethal lymphoma masking itself behind Castleman-like tissue changes. For instance, nodal TFH cell lymphoma can present with hypervascularity, expanded dendritic networks, and plasmacytosis that look virtually identical to IMCD on standard H&E stains. Exposing the lymphoma requires hunting for specific markers: an atypical CD4-positive T-cell population, PD-1 positivity, and definitive proof of T-cell clonality. The golden rule of this diagnostic space remains absolute. The moment you detect light chain-restricted cells or an aberrant flow cytometric population, you must launch an immediate hunt for a clonal neoplasm. The biology separates neatly when you look at the whole patient. IgG4-related disease is a targeted, organ-directed fibroinflammatory state. Multicentric Castleman disease is a systemic, cytokine-driven fire. When clinical data is absent, pathology reporting must be cautious. Terms like Castleman spectrum lymphadenopathy accurately describe the tissue without locking the clinician in a dangerous, unproven diagnosis. As the WHO-5 framework makes clear, examining the tissue is only the opening question. Disease distribution, viral status, and serum parameters are the mandatory answers required to solve the case.